हाय फ्रेंड्स, गुड इवनिंग। आई एम डॉक्टर आशुतोष गुप्ता एंड आई एम ए कंसल्टेंट फीटल मेडिसिन। सो आज हम बात करने वाले पॉलीहाइड्रामनोस के बारे में। राइट, सो इट इज़ अ वेरी वेरी इम्पोर्टेंट फाइंडिंग और बहुत अच्छा केस है। इसके बारे में बात करते हैं। राइट, सो वी कैन डू द amniotic fluid index. So there are a lot of criteria by which to do it. Normally what I do is this, that I divide the uterus into four quadrants, and the upper quadrant and the lower quadrant, and we try to measure the amniotic fluid index and all those stuff, right? Okay, and if it is greater than 24 centimeters, then probably we call it as a polyhydramnios. Okay, so now let us briefly go around the possible etiologies for this polyhydramnios. First and the foremost, that probably I try to look around for the stomach. So the size of the stomach is this, कि वो जो स्टमक है वो पूर्णिमा का चांद होना चाहिए, ईद का चांद नहीं होना चाहिए. So meaning thereby that the stomach should be full. So if it is full, meaning thereby that we have ruled out myotonic dystrophy, congenital myotonia, esophageal dysmotility, any sort of a ventriculomegaly, and therefore the inability to swallow, right? And then we put the color Doppler across the nose and try to look around for the posterior corneal atresia, which also gets ruled out, and H-shaped variety of tracheal fistula also gets ruled out, right? And then we can have some issues with the kidneys, and therefore we might have a salt-losing nephropathy, Bartter syndrome, and so on and so forth. And we can have a fibroid. We can have a choreangioma. We can have a choreangioma in the placenta, and therefore that can behave as an AV fistula, and therefore can lead to polyhydramnios, right? But the most important part is this neurarthrogryposis, right? So many a times we identify that with polyhydramnios, if it is a typical position of the baby, like hyperextended legs, right? With every joint, we do have the flexors and the extensors. So by default, in utero, the tone of the flexors is more as compared to the extensors. So meaning thereby that the fetus at every joint, cervical spine, elbow, a shoulder, hip joint, a knee joint, the flexors are, the tone of the flexors is more as compared to the extensors. Even though we identify that the biceps has got two heads as compared to the three heads in the triceps, but the tone of the biceps is more as compared to triceps, and therefore the baby would be internally adducted, and therefore the elbow would be flexed, right? So the any sort of an hyperextension, very sluggish fetal movements, and a typical sort of an club foot to the babies, and babies very sluggish to move, can pinpoint to a neuroarthrogryposis. Pehla. And then we can have those central so you can have a lot of genetic conditions leading to this central hypotonia to the baby, and SMA is one of them, spinal muscular atrophy. Right, so let us first go through this case and then probably we'll discuss it out. Now look around carefully to this fetus. Hyperextended knee joint. So bilateral, दोनों तरफ ही hyperextended knee joint है. Now try to look around for the feet. And then the feet is also slightly, है ना, club foot, mild variety of a club foot. Very mild sluggish movement of the baby, even though I'm trying to stimulate the baby. Right, and then with the polyhydramnios, so the baby is tanking. So we have seen the fetus, we have identified the posture, we have looked on for the amniotic fluid index. So it is a polyhydramnios with this typical position of hyperextended limbs and very sluggish fetal movements. And then since the tone is not there, and therefore the foot also goes into slight amount of an club foot, right? And then probably you keep the baby under observation and then identify and then try to comment upon the movements of the baby and whether the baby from that hyperextended position gets into a flexed position. If it doesn't, probably we are dealing with some neuroarthrogryposis. So this is the basic pathology and therefore leading to this polyhydramnios. Pehla. Dusra, with this amniotic fluid, the baby is tanking in the amniotic fluid. So baby is always lying in the posterior wall of the uterus. Otherwise, what happens is that the baby is usually lying in the middle part of the uterus. So tanking fetus with polyhydramnios, it is also not a very good sign. So it is a sinister sign. So try to look around for the hyperextended limbs. Similarly, the position of the ankle and mild club foot and the sluggish movements, polyhydramnios and tanking to the baby and tanking of the fetus into the amniotic fluid into the posterior wall of the uterus also suggests something sinister, and this could be an neuroarthrogrypotic or probably so probably then we can talk about multiple pterygium syndrome and all those stuff, and fetal akinase deformation syndrome and blah blah blah. But all these things, they really don't happen But SMA, spinal muscular atrophy, is a very strong possibility. So all these things they need to be looked at very carefully before we can really label, and therefore we can make all this prospective diagnosis. Right? Eventually, even though we are beyond this amniotic fluid, but probably we can identify and then we can offer the carrier screening to the parents. Right? So MSML, so the MLPA for an SMA can be identified and could be offered for the parents so as to identify the SMA carrier status. If they are carriers, then probably then the baby could be affected. Right? Thank you very much for your patience.